Good evening, I'm Professor Nick James. I'm Professor of Oncology at the University of Warwick and Consultant Clinical Oncologist at the Queen Elizabeth Hospital in Birmingham. I've been speaking today at the RSM's Winter Urology meeting about recent updates in bladder cancer and in particular clinical things that have interested me in the last year. So I looked at a number of different areas. So the first of these has been the explosion of new treatments targeting the programmed death pathway, the PD-1 pathway. And so this is a pathway that the cancer cells use to evade the immune response. So basically it's like an invisibility cloak. They put out molecules that block the immune system from switching itself on. So there's been recently a number of drugs developed which will target these PD-1 pathway chemicals and therefore prevents the cancer from evading the immune system. So you're releasing the immune system to attack the cancer. So early results published in 2014 from a phase 1 trial of one of these agents in relapsed disease showed very exciting response rate, including long-term remissions, which is very, very unusual in a phase 1 trial in the relapsed metastatic setting in any cancer, in particular in bladder cancer, where there's been dismally little progress in the last 30 years, really. So these drugs, there's a number of them now, are all in phase 3 trials across the whole range of disease spectrum, from high-risk non-invasive through neoadjuvant, synchronous with radiotherapy, adjuvant, metastatic, both first and second line. I think we can expect to see a number of approvals over the coming months and years in a whole range of settings. And I think these will genuinely improve the prognosis of bladder cancer in a whole range of settings for the first time in many years. The second area I wanted to focus on was around the question of adjuvant therapy, because there were two important studies published last year. The first one was the long-awaited, long-delayed EORTC adjuvant chemotherapy study. So this trial failed to accrue to target, largely because it was actually quite hard to find patients fit enough for adjuvant therapy post-cystectomy. So that was a real block for us in the clinic, in our centre, for getting patients in the trial, and I assume that was the case everywhere because pretty much everybody failed to recruit. Anyway, there were enough patients in the trial in the end with enough follow-up to give us some data, and what they show is an improvement in failure-free survival with upfront adjuvant chemotherapy post-operatively. That translated into a trend to improve survival which didn't hit statistical significance. To my mind, though, the significance of these results is less than you might imagine, because we have level 1 evidence in the neoadjuvant setting that chemotherapy improves outcomes. So we already know chemotherapy improves outcomes. And the fact that this trial failed to accrue shows that there are technical delivery difficulties in the post-operative setting. One of the advantages that people have previously cited for adjuvant chemo is that you can select the patients that really need it. But one of the striking features of the EORTC trial was that there was no subgroups that benefited particularly. So T-stage, N-stage, numbers of nodes removed, none of it allowed you to predict a group that either did or did not need adjuvant chemo. So the one claimed advantage of adjuvant therapy, selecting the right patients, clearly doesn't apply. With level 1 evidence for the neoadjuvant setting rather than the adjuvant setting, to me that study in particular nails it, that neoadjuvant is the right place to put perioperative chemo, not post-operatively. Finally, I was talking about data relating to different prognostic factors from our BC 2001 trial. So one of the things that came out very clearly from the data is that residual mass is the same as high stage. Now, residual mass post-TURBT is often cited as a reason to do a cystectomy, but I think all that the residual mass is telling you is that this is a high-stage tumour, and that will do poorly with cystectomy or radiotherapy, so it doesn't help you select, so it's a prognostic and not a predictive factor. Our data also clearly showed that whether you had a good or a poor prognosis bladder tumour, there was still an uplift in your outcomes from synchronous chemotherapy on top of the radiotherapy. So although you can identify patients who were going to do poorly, they did less poorly if you gave them more treatment, which actually we had already previously published was relatively low toxicity. Finally, I was talking about a new trial which we're launching, which is called Bladder. So one of the things that has been a feature of muscle-invasive bladder cancer management for half a century, probably maybe more, is TURBT, which is used as a sort of hybrid of a diagnostic test, a staging test, and a partial treatment. Now, if you've got non-muscle invasive disease, it actually ticks all of those boxes. You excise the tumour, you get the grade, you get the stage, and you've treated it. Now, for muscle invasive cancer, we've been arguing that this is actually an unhelpful procedure because it confuses the subsequent radiological staging. It's not a good treatment. You're delaying the correct treatment, cystectomy, radiotherapy, whatever it happens to be. And so we've just got funding for the NHS Health Technology Agency to do a randomised trial. So for patients with suspected muscle-invasive bladder cancer identified at flexible cystoscopy, we will simply do a pinch biopsy at flexible cystoscopy, which will give you the tumour grade and the fact that it's cancer or non-cancer. So if it's a high-grade tumour and looks like it might be muscle-invasive, they will then be randomised to a TURBT or a multiparametric MRI. The multiparametric MRI identifies these patients as having probable muscle-invasive disease. They will proceed direct to whatever the correct treatment is felt to be, surgery, radiotherapy, chemotherapy, it doesn't matter. We hypothesise that by doing this, we'll greatly shorten the time to the correct treatment for these patients. Currently, it runs at about 100 days for muscle-invasive bladder cancer. We think we can shorten that hugely by doing a scan that identifies the patients who need the treatment and proceeding to the correct treatment. If we're correct and we can shorten the time to treatment, we also would predict that we would improve outcomes because you're getting the right treatment more quickly. So the final outcome measure for the trial will be time to progression, which we hypothesise should come down. We're initially starting the trial as a pilot in 3 centres so we can debug the imaging protocols. If it looks feasible and safe and so on, we'll roll it out into a much larger study, aiming to recruit 900 patients in all. That was my final bit to my talk. Thank you.